where you're logging on from. I'm Nicole Shen from Houston, Texas. Hi, Michelle.
Hi, hello. I'm glad to be back. It was well missed.
I know we missed you. This evening, we're going to be talking about family planning and reproductive options for SDS families. SDSF Live is brought to you from the Shwachman-Diamond Syndrome Foundation, providing support to families around the world. The show is public. Please do not ask or share any personal information that you are not comfortable sharing. These shows serve as a library of topics on YouTube for families to access later. I'm excited to introduce you to our guest in just a minute, Sandra Darilek, the Assistant Professor and Co-Manager of Prenatal Genetics Services at Baylor College of Medicine in Houston, Texas. Hi, Sandra.
Hi.
Hi, thank you. Welcome.
Thanks for having me.
So Sandra and I are both in Houston. Michelle is in Michigan. Sandra, can you tell us a little bit about yourself?
So I am a genetic counselor. Hopefully some of you guys have had interactions with genetic counselors at some point in time. If you haven't, I hope you get to meet one of us at some point. I have been working at Baylor College of Medicine for about 17, almost 18 years in reproductive genetics. So I work with women during their pregnancies and women and couples who are trying to achieve pregnancies to give them an awareness of what their options are. It's a challenging specialty, but it's a very rewarding specialty at the same time. So, and Nicole is an old friend from the work side of things. So, yeah.
So I just want to mention that we are going to be focused on the family planning and reproductive options. We are going to have Dr. Joanna Romans on probably in June to discuss SDS genetics at length and more of the less common SDS genes or the newer genes. Just a little bit of full disclosure. I do know Sandra it was actually almost exactly 6 years ago that I met Sandra. My son Roman, who's now 6.5, when he was 4 months old, he was clinically diagnosed with SDS, and we waited about 6 to 8 weeks for the genetics to come back. But in that time, we met with another, one of probably your coworkers, genetic counselors, and she had told us how SDS works with the gene, and if we had the gene, and how if we did have the gene, we could possibly have more kids. And we discussed that we already did fertility options to have my son, and then Roman was diagnosed genetically at 6 months old, and we found out that he also has no bone marrow match in the world. And so we instantly met you, Sandra, and started talking about if we were to have another child, what did that look like, and how do we make another bone marrow match, or I'm sorry, a bone marrow match in addition to a healthy child for my son. And so that took 3 years, and I did 4 rounds of IVF. Sandra and I worked a year on trying to get the money and getting insurance to pay for it. And then my husband and I saved a lot, and I did 1 year of 4 IVFs back to back. I made 43 embryos. 2 were healthy and a bone marrow match to my son. And I now have a 2-year-old beautiful daughter named Luciana, and she's a perfect bone marrow match to my son. So I'm an open book, and you could ask me as many questions as you want during the show as well. So
and I think I want to segue that by saying, like, please submit your questions via the comments. We want to answer them. Not me personally. I'm just here for the looks. Other smart people want to answer them. And so be sure you are submitting them. However, be aware that we cannot give medical advice based on what you would need from a doctor's appointment. So please keep them as general as possible.
Oh, and a reminder, Michelle is on the clinical side. So yes. She could maybe share a little bit of her personal as well. So Sandra's going to be covering both, but obviously there's going to be more options for genetic. So Sandra,
I think that's my favorite part about you and I, Nicole, is that we can see things from 2 different sides of the coin on so many different things. And this is the one area I have no expertise in. We've never had to seek genetic counseling. Nathan was our last child. We had no plans after that because we're very tired. So
thank you. Okay, Sandra, all you.
All right. So I'm going to actually move things around a little bit so that I can see my slides mainly. So, so Nicole asked me to present mainly on reproductive options, but also give a little bit of a review of the genetics of SDS. So I'm also going to go through that with you guys. So this is kind of what I'll be hitting the high points of today. A little bit of review of the genetics of SDS, diving deeper into the reproductive options, the various things that you can consider. And then the last part will be really the considerations. It's great to know about the reproductive options, but I think part of the role that genetic counselors play in healthcare is to also help families think through, well, what do I need to consider if I'm thinking about these different options? And so I wanted to go through some of that with you guys as well, or at least set a foundation. So some of you may be very well educated about the genetics of SDS, and if so, this is going to be a big review for you. For those who haven't had a genetics discussion recently and need a refresher, hopefully this will be a little bit helpful. As a lot of you are probably aware, SDS is not a common condition, though I work in genetics and almost everything that I deal with is relatively rare. It's estimated that less than 1 in 100,000 people has a diagnosis of SDS. Very likely this may be an underestimate. I think a lot of people believe that that some people go undiagnosed with SDS, or we don't recognize what the diagnosis is. Based on that, we know that the carrier frequency, the chance of a parent or a person being a carrier of SDS, is estimated to be about 1 in every 130 people. That may either be more frequent than you thought it would be, or less frequent than what you would thought it would be, depending on what you're thinking about. To put in perspective, cystic fibrosis, which is one of the most common genetic conditions, has about a 1 in 25 to a 1 in 50 carrier frequency. So this is, probably 5 to 6 times less common than cystic fibrosis. Currently, we're aware of about 4 genes that have been identified. Now, I am not an SDS researcher, so there's probably more that your other, well-educated SDS experts will clarify for you guys as Nicole and Michelle bring them in. But currently, there are 4 genes that have been established to be associated with SDS. About 92% of genetically diagnosed cases have 2 variants in a gene called SBDS. The other 3 genes that are associated with SDS make up less than 1% of cases each. The other 3 genes are EFL1, DNA GC21, and SRP54. As you guys can see, genesis like letters and numbers that seem like a lot of gibberish to name genes, but that's how it goes. A little bit less, or it's estimated that less than 10% of cases go without a molecular diagnosis. So those are our cases that have a clinical diagnosis, but when we do the molecular genetic testing, we don't find a variant or variants in any of these 4 genes. And so that doesn't mean you don't have that diagnosis. It just means that the genetics hasn't caught up yet, and we don't know what gene is the underlying cause for that subset of SDS. Generally, and most cases of SDS are autosomal recessive conditions, and I'm going to kind of give you a reminder of what that is. The 3 genes that are associated with the autosomal recessive form of SDS are SBDS, DNA JC21, and EFL1. There's also an autosomal dominant form of SDS, and that is less than 1% of cases, but that's tied to the gene SRP54. To take you back to genetics a little bit, if you're like most people that I talk to, you got genetics in high school, maybe in college, and thought you'd never use it again and packed it away. And so just as a reminder, we all have about 20,000 genes. We have 2 copies of most of our genes, one that we get from our mom and one that we get from our dad. So a recessive condition is a condition where both copies of the gene have to not work. And that's what we see with most cases of SDS, that a child has, when we can get a genetic diagnosis, 2 non-working copies of one of those 3 genes. But for the SRP54 gene, it's different. It's a dominant form. And what that means is that having one non-working copy of the gene is enough to cause the condition. And so we've been learning over time that conditions that we thought had one inheritance pattern sometimes have more than one inheritance pattern. And that's just the complexity of genetics. To give you a reminder of how that works and what that means for risks going forward with standard recessive inheritance. So if your child has a recessive form of SDS and it's been genetically confirmed, very likely that means that both parents are carriers of SDS. And so what that means is they each have a working copy and a non-working copy of the gene. And again, having that working copy for a recessive condition is enough to keep you completely healthy. What that means when they have children is that with every pregnancy, there is a 1 in 4 chance that they will both pass on the non-working copy of the gene that they carry, and they will have another child who's affected with SDS. 50% of the time, they will pass on one copy of the gene. One parent will pass on a working copy of the gene. The other parent will pass on a non-working copy of the gene, or vice versa. In that scenario, the children will be carriers like their parents. Won't have any symptoms of the condition, but will be carriers. And then 25% of the time, they'll pass on both non-working copies of the gene, and that child will not have SDS, but also will not be a carrier and won't be at increased risk for having a child with SDS. So if you have a child with an autosomal recessive form of SDS, we would expect that 25% risk in every pregnancy that you have. Often parents are also thinking about their children's future. So I wanted to also kind of give you guys some information about what does it look like for your kids in the future, because hopefully they may have families one day. And that is really dependent. If we're dealing with an autosomal recessive form of SDS, it really depends on their partner. Whether their child is going to have SDS or be at risk for SDS depends on their partner's carrier status. So we know that anybody who has a recessive form of SDS, all of their children are going to be carriers because they've got 2 non-working copies of the gene. So they're always going to pass on that non-working copy of the gene. But whether their children will get 2 non-working copies depends on their partner. So if they have a partner who is not a carrier for SDS, then while all of their children will be carriers, none of their children will be at risk for SDS. On the other hand, if they do have a partner who is a carrier, then the odds change. Their odds would be different than what their parents' odds were. Their parents had 25% risk because both parents were just carriers. But if you have a child who has SDS, who's now an adult with SDS, and if they have a partner who's a carrier of SDS, then it goes to a 50-50 risk. 50% chance that a child will get that carrier parent's non-working copy of the gene in addition to their parent with SDS's non-working copy of the gene and have SDS, and a 50% chance that they will just be a carrier. I do want to make a point about one thing. You have to be a carrier of the same gene when it comes to SDS. So if you have a child who, say, has 2 variants in SBDS, if their partner happens to be a carrier of a different form of SDS for one of those other genes, it's not going to have that risk. But if they're both carriers, or if they both carry variants in that same gene, that is when there is going to be a risk. Now, if you happen to have 2 adults who both happen to have SDS and then go on to have children, then all of their children will have SDS because they only have non-working copies of the gene to work with. I don't know that we see that commonly in SDS, but we certainly have seen that in other recessive conditions, hearing loss being a very common form of recessive conditions where you can have 2 parents who have the same form of hearing loss that go on to have children. It's a little bit different if you're dealing with the autosomal dominant form of SDS, because most of the time when you have a child who has an autosomal dominant form of SDS, they're actually the first person in the family to have SDS. Wasn't inherited from a parent. Their parent didn't actually have a genetic change that they passed on. It was a new change in their own DNA. But now that it's in their own DNA, they have a chance of passing it on to their children. So if you have a couple who have a child with autosomal dominant SDS, we usually say that the risk is probably less than 5% or so to have another child with SDS. But if that child grows up and then has a family of their own, they will have a 50% chance of passing on that variant that they carried that was enough to cause SDS for them. And there's a 50% chance they won't pass on that variant. So half of their children would be expected to have SDS, half of their children would be expected to be unaffected. So just a quick genetics review, and I'm happy to dive into questions if you have any at the end about the genetics. But I want to spend more time on the reproductive options, since that's why I was asked to come and talk to you guys today. I wanted to start out with, kind of the typical options. And this is, if you get pregnant naturally, don't, go out of your way to do anything more aggressive. What are your options? Because there are options if we've got a molecularly confirmed form of SDS. So if we have genetic testing that found the variants in your child, then we do have options prenatally. They are done through one of two procedures. On the left side of the screen, you're seeing an image that is showing you what a CVS looks like. CVS stands for chorionic villus sampling, and that's just the fancy term to describe part of the placental tissue. The outer edge of the placenta is what we call the chorionic villi, and that's what they are actually taking a small sample of when we do a CVS. This is done between 10 and 14 weeks of pregnancy. And since the DNA in the placenta should match the DNA within the baby, by getting a sample of the placenta, we get DNA that tells us what the baby's DNA looks like. Amniocentesis is probably the procedure more people have actually heard about if they've heard about one of these two options. It's done a little bit later in pregnancy. It usually can be done as early as 15 to 16 weeks of pregnancy and anytime after that. The difference here is that instead of taking a sample of the placenta, we're actually inserting the needle into the sac around the baby and taking a little bit of fluid. So we're not touching the baby with the needle when we do an amniocentesis, but we do take a little bit of fluid, and inside that fluid are skin cells from the baby. And that again gives us the baby's genetic information. So if we know what the genetic changes were in the child who had SDS in the family, we can use that information and look for those same genetic changes, either on the CVS sample or the amniocentesis sample. The benefit is that this is what we call a diagnostic test. This tells us whether the baby has the two variants that we saw in the other child, if we're dealing with the common recessive form of this, one and is just a carrier, or neither of those variants. But there is a trade-off for this prenatal information. Both the CVS and the amniocentesis do have a risk. They both have a risk that includes the risk for pregnancy loss or miscarriage. With CVS at a good center and experienced hands, the risk is estimated to be about 1 in 450. With amniocentesis, again, in a good center and experienced hands, the risk is estimated to be about 1 in 900. For some people, this information is helpful. It tells them what they need to know. It helps them plan. It helps them make decisions. For other people, the risk does not outweigh the benefit of getting that information during the pregnancy. And so it can be a very personal decision about whether you do want to know this information during a pregnancy or not. You also can do HLA typing on prenatal samples if that's needed. And so that's something else that can usually be done at the same time if necessary. Now, the other option we have, again, if you've got a genetically confirmed form of SDS, is going the route that Nicole talked about, going through in vitro fertilization, what I'm going to refer to as IVF moving forward, and using something called pre-implantation genetic testing, or PGT. There's several different forms of prenatal genetic testing. The type that we are focusing on, because we're dealing with an inherited condition like SDS, is what we call PGT-M, and the M just stands for monogenic disorder or single gene condition. IVF and embryo testing through Pgt is a process. And that is probably the most important aspect of what you hear me say. This is a process. There are multiple steps. There's a timeline that goes into this. And it really has two phases. It has the phase that is the actual setup of the testing of the Pgt itself, and then it's actually walking through the process of IVF. The way embryo testing is done is actually very different from any other genetic testing that we do. For embryo testing, we actually, the labs that do this testing actually set up testing specific to the family that is undergoing the testing. So most of the time when we do prenatal testing or we do postnatal testing on a child or an adult, there's a set test that you order. It's run the same way every single time. You don't need any prep work. But that's not how it works with embryo testing. Embryo testing is highly specialized. It's very specific to the family, and that's partly because you're dealing with a really small sample, and it's partly because we want to make it as accurate as possible. So it does take about 4 to 6 weeks to actually set up a test prior to doing IVF and to make sure that test works before we can actually be certain that we'll get good information on the embryos. And to set that up, it actually requires DNA being sent to the lab from the parents as well as the child who has SDS in the family. So they need those 3 samples to actually set up the testing. At the same time, often anybody who's considering IVF is going through an IVF evaluation. So a lot of the families that I work with that are doing IVF for a genetic condition don't have fertility problems necessarily. Some of them do, but a lot of them don't. But despite the fact that we may not suspect there to be any challenge getting pregnant, every couple going through IVF has to be fully evaluated because we want to make sure that there aren't any obstacles that we might run up against as part of the process. So usually there's a lot of pre-testing. The woman goes through blood work, imaging, the husband goes through blood work and sperm analysis, and we make sure that everything looks good on that end. And once they get through that initial evaluation and we don't see any concerns, once the lab has set up the testing for the embryos, then you can actually start the IVF process, which you go through something called ovarian stimulation, where you're on medication, injections, daily injections of medication for about 2 weeks, plus or minus a few days. At the end of that period, they do something called an egg retrieval, where they actually remove the eggs that have been produced by that hormone protocol or that hormone medication they've been giving the woman for 2 weeks. They retrieve those eggs from the ovaries through a biopsy type of procedure. They then fertilize those eggs with the partner's sperm and then allow those embryos to grow for 5 or 6 days in the lab. At that point, that's where the embryo testing begins. So after 5 or 6 days of embryo growth, they actually do a biopsy of the embryos to provide us with a DNA sample for each embryo. And they do that by taking a small sample of cells from the very outer edge of the embryo. At that point, embryos are frozen so that they can stay in a status where we can use them until we get the test results. And that sample that's biopsied from every embryo that was tested then goes to the lab that did all of the setup for the testing. And they run an analysis, get us test results. And then those test results go back to the IVF specialist and they look at those results to figure out, okay, which embryos are not affected with, in this case, SDS. And then they look at the quality of the embryos. And they use both of those sets of information to decide which embryo we're going to transfer. They then thaw the best looking negative tested embryo and we transfer it to the woman's uterus. And at that point, we hope things go well. We hope the embryo does what it's supposed to do. And that means that it actually implants into the uterus, grows, becomes a good solid pregnancy. Probably one of the biggest frustrating aspects of IVF and one of the biggest disappointments with IVF is just going through IVF successfully. Just having embryos to transfer doesn't guarantee a pregnancy, doesn't mean that you're going to have a pregnancy after all of that work. And so that can make decisions about whether to go through IVF or how many times to go through IVF challenging. So those are the overviews. If you've got a genetic diagnosis of the testing we have available, testing that's available to us during pregnancy, testing that's available to us prior to pregnancy to try to reduce risk for SDS as much as possible. But I wanted to dive deeper into the considerations of actually both of those options, and then also circle back to the families that don't have a genetic diagnosis to also talk about what options they may have if they're still thinking about expanding their families. So what other things do we need to think about? Well, most people that I talk to when they get to me for reproductive genetic counseling often have heard that prenatal testing might be available for the condition that's running through their family. Probably a smaller percentage of people have heard that embryo testing is an option. And most people think that those are the only two options that are available. And from a genetic testing perspective, they are. But that doesn't mean that they're the only reproductive options. For some families, the risk with a spontaneous conception is too high. IVF is either too expensive or just more than they can see going through. And so for them, other things you could consider as a way to try to reduce risk are things like using an egg donor or a sperm donor. If you use an egg donor, it usually still requires IVF. If you use a sperm donor, it does not necessarily require IVF. Those are challenging decisions to make, to take one parent's biological component off the table for a pregnancy, but it is a way to reduce risk by choosing an egg donor or sperm donor who's not a carrier of SDS. For some families, adoption is an option. If getting pregnant naturally, IVF, using a donor are not viable options, adoption could be another route to go. And for other families, it's choosing not to expand their family, choosing not to have additional children at this point in time or in the future. And so while most of what I talk about is the prenatal testing options and the embryo testing options, these three options are also reproductive options for any family who has a genetic diagnosis. For the families that have a clinical diagnosis, the challenge there is that we don't have that genetic confirmation. So prenatal testing and pre-implantation testing absolutely require the child to have a documented, detectable genetic variant. Without that information, we don't know where to look. And without knowing where to look, we just don't have a way to do prenatal testing or embryo testing. That doesn't mean that there aren't options for these families. They're just not as big a plate of options. So again, spontaneous conception is still an option. If you're comfortable with, kind of the risk of having another child with SDS and have, kind of decided that's the route you want to go. Can't offer you anything prenatally. Ultrasound during pregnancy is not going to be very helpful for us. So with this route, we would recommend a clinical diagnosis, a clinical evaluation after the child is born. They also have the option of using an egg donor or a sperm donor. So despite the fact that we don't know the genetic cause, you could consider an egg donor or sperm donor. Of course, we can't test the egg donor or sperm donor to see if they're a carrier, but again, more likely than not, they're not going to be a carrier. Adoption is also an option in that scenario. And then as well, not expanding your family, being kind of content with what your family looks like at that point in time are the options. One other thing I wanted to bring up, especially with the fact that we're continually learning about new genes, is if you don't have a genetic diagnosis in your child, but are still actively considering expanding your family, even if you're not actively considering expanding your family, you might want to talk to your doctor periodically about additional testing options. Now, for a lot of children that have a clinical diagnosis of a genetic condition, We'll consider things like whole exome or whole genome sequencing testing. These are the types of tests that have really led to gene discovery in the last few years. And it's possible that in some cases we may actually find a variant in a gene that maybe we are suspicious is associated with a condition like SDS, and we're starting to learn more about that. So I wanted to bring that up as a way to just revisit, because genetics is always continually evolving, and I don't think that we're anywhere near knowing everything we need to know about all of the genetic diseases that are out there. Another thing I wanted to touch on, because HLA matching and HLA type, or finding an HLA match is such a big aspect of this particular condition. A lot of genetic conditions, HLA typing and needing a match isn't an issue whatsoever. But for a lot of the hematological conditions that I see families for, HLA matches are a very big aspect of what we're looking for. And so if you are in the situation like Nicole was in, where you were hoping to have a child who didn't have SDS, but also could be an HLA match for a sibling, that is also something we can do with IVF and embryo testing. The exact same process. You go through embryo testing after you've done IVF. The difference is the odds. So if you're going into IVF and you're wanting to just reduce the chance of having another child who has SDS, what we know is that we would expect 75% of your embryos, or 3 out of every 4 of your embryos, to either just be a carrier or not even be a carrier. So if you had, for example, 4 embryos, we would expect 3 of those would be of the type that we could transfer. Now, if you layer HLA typing for a match on top of that, that changes the odds. It actually changes the odds pretty significantly, because with HLA typing, if you're looking for an identical match, we know that 1 out of 4 embryos would be an identical match. And so if you combine those numbers, you go from 3 out of 4 embryos that could be transferred to 3 out of 16 embryos that could be transferred, from 75% of the embryos to about 19% of the embryos being exactly what you were hoping for. And so I think it's important to set those expectations on the front end, to know how those numbers look different. Now, while for the clinical families, we can't test for SDS without a known genetic variant, we can still do HLA typing. So IVF with embryo testing for an HLA match is still an option for clinical families if that's something that they need. Another thing I like to bring up, especially if you're thinking about IVF, or if any of you are kind of in the process of going through IVF, often IVF doctors will offer you the ability to do additional testing. And usually that's something called Pgta, which is a type of embryo testing that tests for chromosome abnormalities. It can screen for conditions like Down syndrome. And so this is an option that's very often offered. It's not something that you have to do along with your other embryo testing. But I think an important aspect of this is that it can also reduce the number of embryos that you have that are genetically looking the way you want them to. Every time you do a test on the embryos, it is going to screen out some embryos, and so you're going to be lowering your numbers. And so that's an important aspect to know. Probably the biggest question I get about IVF and embryo testing is it covered by insurance, and what's the cost? This is also probably the biggest obstacle for families before they're able to do IVF. And it's probably actually the biggest obstacle that keeps people from going down the road of this option. Cost and coverage through insurance is a moving target on a good day, and you guys probably know that better than anybody else. I think anybody who has a child, or they themselves has a condition that requires a lot of medical care, knows that it can be difficult to know what insurance costs and coverage is going to look like. With IVF, And embryo testing, it's kind of multiple pieces. One, the question is, does your insurance policy actually cover IVF? And if it does, are there specific criteria that you have to meet? A lot of policies, you have to meet very specific criteria before IVF is even a covered benefit. Now, some states in the country have better coverage that is mandated on insurance policies. Others do not mandate IVF coverage. So that's one part of it. The other part is the embryo testing covered? And you can get a mixture. I have some patients that have no IVF coverage benefits, but have embryo testing coverage, which is interesting because you can't do one without the other. I have some patients who have IVF benefits and no embryo testing coverage. I have some people that have both and some people that have none. And quite honestly, until we actually ask insurance very specifically, are these covered benefits? What are the criteria? We often don't know. So on the cost side of things, if you take insurance off the table and just kind of go worst case scenario, if insurance doesn't cover this, what are we looking at? If you look at a single cycle of IVF, start to finish, so starting with the medications through egg retrieval, fertilization, testing of embryos, and a transfer of a single embryo, you're probably looking at about $20,000 to $25,000 for that cost. Most of that being made up by the IVF costs, a smaller percentage of it being made by the embryo testing cost. If you have to go through multiple rounds of IVF, fresh cycles, then that adds to the cost. There are things to think about on both sides of the coin, things to think about with IVF and things to think about with spontaneous or natural conception. And I just wanted to throw these out to get wheels turning if anybody's in the boat of thinking about these options. If you're considering IVF, some things that you need to think about include the fact that, one, IVF doesn't guarantee a pregnancy. So again, you can invest all the time, all the money, all the emotion into this process, and at the end of the day, have embryos to transfer, but still not have a pregnancy, or have no embryos to transfer. So it doesn't guarantee a pregnancy. IVF with the embryo testing, the Pgta, doesn't eliminate the risk for SDS. Nobody's going to give you 100% accuracy when they test an embryo. Most labs will give you 98% accuracy, which is pretty darn good, but it doesn't eliminate the risk completely. So we still do recommend testing either during pregnancy or after birth to confirm that negative result that we got in the embryo that was transferred. It's a very different approach to prenatal testing or postnatal testing because you're going in expecting a negative instead of going in with that 25% risk, but we still recommend confirmation. IVF with Pgta is very targeted. So you're not testing for everything. You're not testing for all genetic conditions. You're not testing for all chromosome conditions. You're testing for, in most cases, one condition or maybe two. So if you do embryo testing, you haven't reduced the risk for all genetic disease. You also have to think about how you feel about IVF, the costs, the financial costs, the physical costs, the emotional costs, the psychological costs. You really have to think hard about how you feel about creating embryos, testing embryos, choosing embryos, and then ultimately potentially discarding embryos as well, because those are all choices that are going to be made along the way. And I think it's important on the front end to know how you feel about those so that you don't get stuck in a hard situation on the back end of something like IVF. You need to think about what you're going to do if you have no embryos to transfer. Does that mean another round of IVF? Does that mean that you stop? Where do you go from there? You also have to think about what happens if you have extra embryos. Now, that may not be the common case of having a lot of extra embryos, but some couples do have more embryos than they were expecting to have. And you might be fully on board for having 2 or 3 children, but if you've got 2 or 3 extra embryos beyond that, you have to decide what you're going to do with those other embryos. That doesn't mean that the spontaneous conception side of things is easy as far as considerations goes. It has its own set of considerations, because if you get pregnant naturally or spontaneously, your option is prenatal testing, and you have to decide how you feel about prenatal testing. Is it something that you want to do? Is it not something that you want to do? How do you feel about the risks? What are you going to do with that information? You have to think about whether you would choose to stop a pregnancy if the baby was diagnosed with SDS. And that is probably a consideration that nobody really wants to have to think about, but it's a question, because the question is, why are you doing the prenatal testing? Are you doing it for preparation, which is a very reasonable approach? I just need to know whether my baby has this condition so that we can prepare for another child who has this condition. Or would you actively intervene in that pregnancy if that were the case? You have to decide how you feel about waiting to know the baby's status after birth or until birth if you decide not to do prenatal testing. So I think that's a lot of the time what people weigh. Do I need to know now? Will I go crazy not knowing until the baby's born one way or another, even if it's not going to change any of our decision making? Or am I okay waiting till the baby's born and figuring that all out after birth? If you've got a genetic diagnosis, you can do DNA testing right after birth. If you've got a clinical diagnosis, then you have to go through that clinical cascade of testing. I wanted to end by just giving you a prettier kind of decision tree, depending on where you fall. So if you're on the genetic diagnosis side of things, you've got a few different options. You've got your spontaneous conception with your prenatal or postnatal diagnosis options. And if you go the prenatal route, your CVS and your amniocentesis options. You've also got the option of IVF with Pgt for SDS, using an egg donor or a sperm donor, or adoption. If you're on the clinical diagnosis side of things, still we've got the spontaneous conception, but the prenatal diagnosis is not on the table. So we do postnatal clinical evaluation. The IVF with Pgt for SDS is not on the table, but the HLA typing still would be if needed. And then you've also got the egg donor and the sperm donor option, or the adoption option. So just kind of a nice tree that breaks it down for the different options that are available. And with that, I am done, and I am happy, along with Nicole, to take questions about any of that information.
This is like really bringing me back.
Do you remember sitting through all of this, Nicole?
I know. I should also add, I've probably called Sandra several hundred times with questions, and she's taken them all, because this is quite a journey when you go through this, and you really you kind of cycle through, like she said, like the emotional and the financial and the physical, like you're just cycling through and making sure you're making all the right decisions. So it's a lot, and having a good genetic counselor on your team really helps like get through that process. So I want to thank you for getting me through all that. But it really takes me back to getting through it. We have some questions. Michelle's gonna ask them.
Yeah, so one of the questions that came in was, are there any foundations or grants available for those who are financially unable to have IVF, or their insurance wouldn't cover it?
So there's a really good support group for infertility, quite honestly, called Resolve. It's resolve.org. And they actually have a full part of their website that's devoted to making IVF affordable. And there are individual, they actually have a list of grants and scholarships that are available to families who can't afford IVF. I feel like, if you've got fertility combined with a genetic diagnosis, it certainly makes you competitive for those types of grants, because you've got, a real story that I think people can really, picture, the struggle with that. So, but there's not tons and tons of money that's available, but there are some resources out there.
I can name 2 families that I know that are in the Cincinnati area that got coverage for their IVF. I don't know if you have to live in Cincinnati or go to that hospital, but well, I think it was just a one-time deal, but they both got coverage for the full IVF. I think you had covered too, Sandra, that in some states or some insurances, they may cover, and actually in my case, we got very close and they were about to cover the PGB, I want to say. And then like right when we started they stopped taking our insurance or something. So they may cover just partial, which is helpful. It's something. So
Yeah, and there's certainly some states that have much better IVF coverage in general.
Definitely.
Texas is not one of them. Massachusetts actually has pretty good IVF benefits. And if on that same site, on the Resolve site, as well as the American Society of Reproductive Medicine, they actually have links to different states and what the coverage, kind of what states mandate coverage for IVF and which ones don't.
New York, I think, is fairly good too.
Yeah, so some are great and then some are not.
And I wanted to, like in Michigan, we have a children's special health care coverage. It's not entirely like state Medicaid, but it's you have to have certain qualification diagnoses. But I know in there, they also have family planning funds for moving forward. So your state might have an option like that. I don't know what our benefits are. I've never utilized them or inquired, but I do know that I get a newsletter that says they have help. So also something to look into. The second question that came through was, what are the international options for IVF and families who are not in the United States? What does it look like overseas?
So it varies country by country. It's a very good question. IVF is a very different world depending on what country you're in. IVF is much more highly regulated in the European Union, especially in Britain. In Britain, you can only do Pgta if you get permission to do it. There are some countries like Italy that don't allow embryo testing. There are actually a lot of options in India and in the Middle East. And a lot of those IVF groups do have connections or are cooperative with U.S. testing labs. So the big Pgta labs here in the United States, actually, most of them have an international presence and do work with IVF groups from different parts of the world. So it is usually less expensive to do IVF in other parts of the world than it is here in the U.S. So I have certainly had families who were interested in doing IVF and actually had their IVF in a different country because it was significantly less expensive, but their testing was actually done by a U.S. company.
I don't know SDS families that have done that, but I know just infertile couples that have done that. It kind of gets tricky though, because the husband, like the wife may be there for a while and then the husband has to keep flying back and forth to give his specimen. So you need both of them there at some point. I was going to say there's some countries too that only allow you to do make so many embryos too, I believe. Like you can't keep. I was able to keep trying. As far as I know, there was no rule of I mean, obviously there's a limit to my body and financially, but there was no law I know of that was cutting me off of trying over and over again. So
yeah, so if you're in a different country, it probably would be good to get connected with a reproductive specialist, and just ask what the limitations are, what the framework is in that country.
For my story, I was very, very, very fortunate that our hematologist brought in a genetic counselor the same day that we were told my son had SDS. She also ran his HLA, which is your bone marrow type, basically, before that, and gave us that information. So again, we met with Sandra literally right after that and and it was 3 years later that I was able to have my daughter. And that, for me, that process took that long for insurance and financially and then physically to make my daughter. So I hope that everyone has met with a genetic counselor, or at least talked through the options if you are thinking about having more children. I do see sometimes on our support page, people ask anecdotally who has had a healthy child, and that could be helpful, I think, at some point. But as Sandra covered the genetics in the beginning, that is the genetics. So asking people, some people have 3 SDS children in their family, some people have 1. it's a roll of the dice every time.
Yeah, I always like to say your body doesn't remember what happened in your last pregnancy. So the odds reset every single time. Yeah.
I've heard theories about the first, like on that same vein, I've heard theories of the first one has SDS and then the second one and third one don't. So it's interesting what people come up with. I'm pregnant now and think like somehow like the baby could come out or something and get tested. Like they're a little confused about that process. So I'm happy that you covered while you're pregnant what you can do.
Yeah.
No, absolutely. It was an eye-opening show. This is a world I don't know a lot about, and it was very interesting to see the side of it, knowing what my friend had gone through and seeing her firsthand account of it, but not really knowing, everything. It's like if someone asks you about SDS, you don't give them everything. You give them just this little nugget. And so it was definitely a good show to sit and watch, even if you have no intention in family planning, just to be there for our fellow families to understand what they do have to go through. And I'm glad to see there is community organizations to help with something like this. Because I can imagine that if you wanted to do this and insurance wouldn't let you. And I remember we were irate when they wouldn't cover our whole exome sequencing, and we fought and we fought and we fought. And it's on the same level of needing to know things.
Yeah, absolutely. Yeah, it would be helpful. I can send you guys the links that I have for those. If you have any families that are wanting links to those, the financial options, I can easily send you those links.
No, we can definitely put them on the website.
Our IVF, we took out a number. We saved a good amount and took out some loans. It turned out none of ours was covered, and I made 43 embryos, so 43 times that many testings turned out to be a lot, and that's not what we were planning for. Yeah, those links would be helpful.
Yeah, definitely. No, this was such a great show, and thank you for being on with us and answering these questions. And I'm sure, if you guys still have more questions, please send them to us, send them to Nicole and I, send them to our email, get them to us somehow. We can get them to Sandra and get them answered for you, because Nicole and I have always said from the beginning, the show is for you guys and we need it to work for you. And so if you have questions, you need them answered.
Sandra, before we let you go and close the show, can you go over what the options are for the embryos, the extra embryos?
So the most straightforward are transferring or discarding. And a lot of people say, well, what does discarding mean? Well, discarding basically means, like any other biologic tissue, those embryos are just discarded. So you think about your blood sample after. So that's standard discarding. Beyond that, to some extent, it does depend on your IVF group and whether they are willing to give you the option to transfer those embryos elsewhere. So if you have additional healthy embryos that you had, more than you needed, there is embryo donation, embryo adoption. So other families can adopt those embryos from you. There is the option of potentially donating those other affected embryos to research if you're comfortable with that option. Again, it depends on if your IVF group is willing to allow those embryos to be shipped outside of the group. So I always recommend that before you get into IVF, you think about what you're going to do with your embryos and you have a discussion with your IVF doctor to know what they allow. Because if they don't allow what you would ultimately need for your peace of mind, then you might need to find an IVF group that does. Because that is sometimes the most challenging place. You're kind of done. And at the beginning, you're so focused on the outcome, having another healthy child, having a child who's an HLA match, that sometimes those other decisions get kind of diluted or drowned out by the other focus. But I think having those things figured out on the front end so that you're not surprised or blindsided by what you're stuck having to decide on the tail end can be really important. So
I had to do fertility to have Roman, not knowing he had IVF. And then I did fertility again, post-Roman, to make a healthy child and a match. And I didn't realize when your first visit's coming in, they have you sign a lot of paperwork about what you're going to do with those embryos. And it includes if one of you passes away, if you guys get divorced, it's a lot of paperwork, and it was very overwhelming. And interestingly, our thoughts on what we wanted to do with those extra embryos totally changed after we had Roman. So we have saved our initial paperwork for Roman. We didn't wind up getting to the IVF stage. We just had to do an IUI, which is the stage before IVF. We said discard, and after we had Roman, we said save them. And I know I'm not the only family doing this, but partly we're saving them for Roman as an option if he has a transplant, if chemo makes him infertile, as an option for him later on. And I heard other families at camp said that they were doing the same thing. I hadn't discussed that with them, but it was interesting because we thought of that, but other families had thought of that. There's a family that said, lots of good information. Thanks, Nicole, because you also were kind and answered all my questions before starting this journey. So again, I'm an open book. I'm willing to help anybody. There was a family internationally that had contacted me years ago, a child of a SDS patient, which is rare, unfortunately, but she thought that she couldn't have children, and because I was open with my story, went and got tested, and now she has a beautiful baby, and didn't think that she was assumed that she would just have an SDS child, and she's a carrier. And so now they have a beautiful, healthy baby, and I'm really happy for her that they went and got tested. As someone said, a lot of paperwork and decisions. I agreed. Had to talk with my husband to figure it all out. It's a lot. It's a lot of paperwork and a lot of big decisions that you're thinking I just want a baby, and it's a lot. Okay, we've taken an hour of your time. Thank you so much, Sandra. I just want to thank you, Sandra, for joining us. If we get any follow-up questions afterward, we'll send them your way.
Absolutely.
Say hi to your dogs.
Yes,
I know.
they're so excited.
We should have told you bring the dogs in. We're very relaxed here.
Might as well just let them on in. It's probably fine.
Except that they tend to start playing in the background, which is
okay.
worse.
We do have upcoming shows on deck. We talked about Joanna Romans, who found was one of the founders of the SDS gene and the cystic fibrosis gene. She'll be on most likely in June. We have an SDS dental show coming up and a grief show coming up. So watch our SDSF Facebook page for show details. And then if you're not on the SDS registry, please join. Please, it's so important. We're more powerful together, and it's just really important that we work on getting all that data in the same registry. So thank you, everyone. Stay safe at home and have a great night.
Wash your hands. Have a good night.
Wash your hands. Bye-bye. Thank you.